I'm Graham Ellis, I'm a consultant geriatrician and I work in Monklands Hospital in Lanarkshire. And frailty is very much our bread and butter. It is our core business as geriatricians. And one of the standout successes of medicine of the 20th and even the 21st century is that people are living longer. And they're not just living longer in poor health, they're living longer with good health, but often on the course of a lifespan people acquire chronic diseases such as diabetes, heart failure, COPD and so on. And often with these chronic diseases comes the concept of frailty. Now frailty has been described as an inability to withstand insult without loss of function. In other words, it's a vulnerability, a state of risk, that a disease or an illness that comes along can produce an episode of acute disability. So we know, and we've known for a long time, that frailty is associated with an increased risk of nursing home admission, with disability and with death. And we know that the inability to identify and to manage frailty appropriately will lead to some of these poor outcomes. The human cost to not managing frailty appropriately is huge, not just for the individual but often for their family. And not only that, we have to consider there is a societal cost to not managing frailty properly, as more patients are admitted to care homes than really should be. And there's even a cost for acute care. When patients are not admitted to the appropriate specialty, they will have a longer length of stay, they will have hospital complications, and it will be an outcome that the hospital will have to pay for in one way or another. And therefore it's absolutely crucial that we get it right for patients with frailty and we get it right straight away. The sooner we're able to identify an older adult has frailty at the front door of a hospital, then the sooner we're able to manage their care appropriately. What that really means is that at the very point that they arrive at the hospital, we need some simple measure, some simple tool that identifies that this patient needs to be handled slightly differently and they need to get appropriate care. And a whole drive of the improvement work is to identify a simple way, a simple tool, something that will capture that as early as possible, as consistently as possible, to enable teams to identify that this patient needs appropriate managed care in a specialty bed. In my experience in meeting patients and their families as a geriatrician, one of the things that they often appreciate is that when they meet with someone who understands what ageing is about, what the impact of frailty is, what their fears are, their fear of disability, their fear of admission to a nursing home, they appreciate the fact that they can talk about these things. They also appreciate the fact that it's not just a medical perspective that I'm taking, but that we're looking at a multidimensional perspective. We're looking at their other issues, their other concerns, and taking them on board in order to deal with them. And I think the families often feel that they appreciate being involved in that discussion and involved in their care, because they're often part of the support, part of the solution for the patient, and actually the patients often want them involved in their care. But critically, they like the ability to talk to someone who understands what it's about, who can plan their care around them, who can bring up all these aspects and think about the longer term, think about the discharge planning, think about the rehabilitation, think about the goals that they want to achieve. What is it that matters to them? What can we do? What can't we do? But able to have that honest and open discussion with someone who gets it. It is a whole system setup. It's about the whole system for the specialty. And identifying someone early is really the beginning of a long and challenging battle to make sure that every patient has the right to specialist care. But it is achievable. It's hugely rewarding when you get it right. And I think sometimes we're able to look back and see that increasingly, year on year, we've been able to bring down length of stay, increase the access to specialty beds and the throughput through those specialty beds, all with the confidence that the patients are getting the right quality of care in the right environment that will lead to reduced poor outcomes, that will lead to the chances of them getting a home to their own house, to their own bed and to their family, and reduce the chances of greater disability, cognitive impairment or death. And being part of that process has been both exciting and challenging, but it is doable, it's rewarding, and it's nice sometimes to go home and feel you've done a good job.